click on the PowerPoint, and then you can just use the arrows.
Okay.
Yeah, and then you'll see people coming in, and then you can just come back to this all the way back to the left. Just hit admit so they can just see what's going on.
Cool.
Yeah.
Well, how about you sit? Proximity to me in case that needs to get taken care of.
I can be right behind you.
Cool. Sweet. So we'll go ahead and get started. It's at 6. But thank you all for joining us for this next pediatric sports lecture. Glad to see you all here. So I'm James Dill. I'm going to do the sports ultrasound, and I'm going to try and orient this presentation towards people who are not necessarily commonly using ultrasound, but are generally familiar with it or may have access to it in their clinics or on the sideline and want to use it a little bit better. If you're someone who's extremely familiar with ultrasound and using it a lot, go get some coffee and recharge, because you're probably going to have seen some of this stuff before. And I credit Dr. Miner and Dr. Moe for some of the cases in here come from them, and so I didn't have to rework the wheel completely for making this presentation. There we go. Cool. I can just tell you next slide. That'll be easier. So no disclosures. Next slide. Basic learning objectives: introduce ultrasound as a safe and effective modality for diagnostics and treatment. Review some basic techniques for the diagnosis of common pediatric sports injuries, and review basic procedures for the treatment of common pediatric sports injuries. So for diagnosis and treatment, when we think pediatric, we'll see this as we go along, not too much ultrasound they're using for really young pediatric patients. I would say this is commonly starting to get applied with sports injuries once kids are in high school, and then from there. Next slide. So ultrasound technology. So we'll go over the physics, and who doesn't want to talk about physics on their evening off? So this is similar to what dolphins and bats use, and submarines as well. So basically, premise is a sound wave is emitted from the probe, and we'll talk about the different probe types. Sound bounces off of an object, and that bounce back is received by the probe, and then that information is taken in and interpreted by the software, and an image is generated. So next slide. So with that in mind, if you're trying to get into different types of tissue, you'll have different types of probes that you're going to use for that. And the two basic ones, there's a cardiac probe we're not going to talk about, because generally in sports ultrasound, you're not using the cardiac probe often, but fundamentally two types when you're using this for sports ultrasound. So there's a linear probe. You can see that one if you're looking at the slides on the left of the screen. So it's a higher frequency. And for that one, you're targeting more superficial structures. So as your frequency gets higher, your energy gets lower. So you have a shallower penetration, but you're getting clearer images. So this is good for structures that are very close to the surface, things in the knee, things in the ankle. However, we have a curvilinear probe. It's a lower frequency, but with that, you get higher energy. So you're going to go for the deeper structures. So this is something, for instance, if you were doing abdominal ultrasound, you're using curvilinear, but you're not really using that much in sports. But this is great for deeper muscular tissues, particularly something like the hip. You can really get a good image. So your image quality deteriorates a little bit, still fairly good with the equipment that we use now, but it's less crisp, less concise, and procedures are a little bit harder on a curvilinear probe, but still definitely possible. So next slide. So with that in mind, we'll talk about interpreting the ultrasound based on tissue densities. So you're sending the sound wave out, it's going to bounce hopefully off of an object and come back to the probe and be interpreted. So depending on how well tissue either bounces the signal back or absorbs and scatters the tissue will influence the way that the probe interprets the image that's coming back to it. So tissue density changes the nature of those rebounding sound waves. So higher density bones, calcium deposits You get direct reflection, so you get this bright white image coming back. Nerves and tendons, they'll partially scatter it, but they're fairly dense. So you still get a brighter signal, but the sound wave is actually able to penetrate it as compared to bone and calcium. Muscles, there's more scattering, therefore poorer reflection, and then fluid. So sound wave hits fluid, it will just scatter and not make it back to the probe. Thus, it's going to be interpreted as a dark area. Next slide. So, oh yeah, we probably need it. Can we hit the light? Can you hit that? Actually, now that we need to look at these slides, we need to hit the light. So this first one, so these, a lot of these ultrasound images are courtesy of AMSSM, but you can look in the, somewhere on the screen with a lot of these ultrasound images, you'll see how they're positioning their ultrasound model and where their probe is positioned. You can see they're looking at a superficial structure, so they're using that linear probe. And this is, they're looking at the subacromial bursa. And so this gives a good example of a lot of those layers. So at the top, you have the skin. Next layer, you have muscle, so it's darker, but there's still some tissue imaging coming in. And then you're hitting musculotendinous area, and so that shows brighter. And so that brighter area that's got some penetration right in the middle, there's a dark strip. That tells you that that's fluid. That's a subacromial bursa. That's a normal one. And there's some fluid in there. We'll look at bursitis later. And then right below that is the densest of all those things. You've got bone. And so very bright line, but nothing underneath that. That tells you it's either bone or a calcium deposit. Next slide. This is another good example. This is a short axis view of the carpal tunnel. So where the mouse is indicating is a nerve bundle, so a medium nerve bundle. It looks like if you take a handful of uncooked pasta and look at it, that's what nerves look like in the short axis. And then around it, you have the tendons going through the carpal tunnel. And below that, super bright structure with nothing behind it but darkness. That's a good example of bone. So next slide. So the other thing to talk about in terms of interpreting these images, if the premise is to send out a sound wave and have it come back to the probe, anisotropy is basically you're changing the tilt angle of the probe. So the sound waves are deflecting off of something, but not returning back to the probe. So this lures you into believing that fluid is present. And this is something to keep in mind if you're going to be looking at one of those more reflective structures like a tendon or a ligament, and you're not at that good 90-degree angle from that structure, the sound wave is going to hit it and then bounce off and tell you there's no sound wave coming back to the probe, so you're going to think that it's fluid. So as your tilt angle increases, the more dense reflective structures like tendons start to disappear first, then nerves disappear, and lastly, muscle is going to disappear. So you can see on the left side of the screen, it's maybe a little hard to see from here, but the on one of the images, the tilt angle is nice and crisp, and so you get a good reflection back. But on the next image, they're at a poor angle, so it's going to start tricking you. Is this fluid? Is it a tear? And so you need to move the probe around to make sure that you have as crisp of an angle as possible, and so that image gets as bright as possible, so you get rid of the anisotropy. Next slide. So this is a good example. This is someone, the long head of the biceps tends to, as it curves around and goes into the joint, if you're not following it, you see how on the right side of the screen, the angle that they have, that they're following it nice and crisp, and they're getting good reflection back. If they did not know about anisotropy and weren't looking for it, as they get to the left side of the screen, they might be tricking into thinking that that bicep is torn. However, they just need to change the tilt angle of the probe to make sure that it's aligning up with the angle of the tendon or the ligament that they're following after. So left side of the screen, anisotropy, trick into thinking it's torn when it's not. Next slide. So why would we use ultrasound? Two primary reasons, diagnostics and therapeutic. So good things about ultrasound, it's available at the bedside. One nice thing about it is you can differentiate between tissue types like we talked about. It's portable, not simply with the machines we have here, but I also, in my little kit, I have a butterfly. If anyone wants to look at it, we can take it out, and I can show you how it works and how awesome the image resolution is with that. And it's just something, a handheld device that hooks up to like an iPad or something like that. So you can use this for sideline coverage. You can transition easily between clinic rooms. Minimal space is occupied by this. Could fit, if you're using like a butterfly, can fit in your backpack. It's dynamic, so we'll talk about this with some of the things we'll be looking at. Unlike a lot of imaging modalities, I can move a patient's extremity and watch as a lumbar is stressed, as a tendon moves with the muscle, something that you can't do with a lot of imaging types. And also Doppler imaging along with that, looking for increased blood flow, arteries versus veins, and inflammation. Therapeutics. So one nice thing is, as I'm looking at someone's complaint with an ultrasound, in that very moment, I can say, we can offer this therapy also at the bedside at the same time. And then therapeutic diagnosis. So I can visualize in real time an injection, which is dynamic. Pain goes away and identify the source of pain. Next slide. So compare this to some other imaging modalities. So for ultrasound, pros available at the bedside. If you have it available, you can appreciate inflammation, radiation. You can offer treatment, dynamic evaluation, and much lower cost. Cons, it's very much user dependent and you can't see inside of bone. Radiographs, it's accessible. You can get them same day if you order them. Lower cost. Acute injury versus delayed healing, a little bit better with radiograph. Cons, there's radiation and it's not really great at soft tissue structures unless something significant's going on. So compared to CT, relatively accessible, can get it same day. I work in the ER as my other job, and it's very much easily accessible from the emergency department. Get really good definition of anatomy on particularly fractures that are more complex, and soft tissue than X-ray, particularly. Cons, way more radiation. It's far more expensive and not great at differentiating inflammation from infection versus other causes that would be causing increased blood flow to different soft tissues. Compare it to MRI. It's accessible, I think, in the sense that, we have it very good at picking up inflammation and good at tissue differentiation. Cons, it's expensive, hard to get the same day, time consuming, and you have to get the dreaded prior authorization for many of these things. So some basic diagnostics that we'll go through. We'll do this in terms of just some cases. The cases are probably really straightforward, but we'll be showing how to use ultrasound in conjunction with your actual physical exam diagnostic skills and history taking. So 16-year-old football player playing around without pads, lands on his shoulder. Now he has pain in the upper portion of the arc of his shoulder movement. Came from, everyone took him to the ER afterward. Of course, we did x-rays, which are always negative. No deformity on his exam. Tender over the lateral shoulder. Range of motion is normal, though he's starting to get pain when he gets into the motion of reaching up. Nerve intact and strength is 5 out of 5. And also while I was on his exam, he has a positive Hawkins and a positive Mears exam. So subacromial bursitis. So we had shown this before. And I'll show you how to go after each of these with an ultrasound and give you the steps to kind of do that. And like I said, I brought the butterfly, so we'll be able to go through something if you want to. So as you can see, this is basically the same image we had before. So that's, if you look in the bottom left side of the screen, it's called a modified CRAS position. It's basically the same position you'd have someone be in if they were like reaching to pull the wallet out of their back pocket. And that will crisp up the image that you want. So the left side of the screen, you have a chromium. On the bottom, that's the humerus. And then that little strip of black fluid, that's the subacromial bursa, that's normal. Can you go back to the previous image? There, you see much more fluid in that. And also, it's one of those exams that's you can do that can be dynamic. If you bring someone up into the empty can position and have them lift their arm above their head, you'll see the supraspinatus dive under the acromion to the left of the screen. And as it does so, you can see that fluid bunch up, and you'll see it coinciding with the reproduction of their pain. Okay, you can go forward now. Case number 2. So 14-year-old pitcher near the end of the second back-to-back game feels a sharp, sudden pain during a fast pitch. Gets aching, sharp pain deep in his shoulder, but it presents more anteriorly. X-rays are once again negative. On exam, no deformity, no overt tenderness, range of motion is normal. Though some pain reaching up. Neurovascular intact, but pretty profound weakness with empty can test. So next slide. So this is a supraspinatus tear. So this is a good example of anisotropy versus actual ligament disruption and fluid. So on the rest of that image, the tendon is, the ultrasound probe is directly on it, and you have nice crisp image. And the difference between, so anisotropy will kind of oftentimes give you like a gradual transition from good tissue to dark. You see this really ratty appearance. This is a full thickness tear. So with tears, you have basically the 3 degrees, a little bit more, and then completely. This is the complete tear that's all the way through. Like I said, so ratty appearance, the dark fluid in between the crisper images, and the tendon is a little bit ratty looking. It doesn't have that nice linear appearance because it's bunching up. So that is a complete tear. And one nice thing about ultrasound too is that this is also user dependent, but you can get a pretty good stage of, if you take your time, you get really good views, you can stage ligament tears. And this one's a stage 3 complete tear. Next one. So this is how you're going to get that image. So if you look down on the bottom left, the ultrasonographer, you start, so supraspinatus, that is above the spine of the scapula, supraspinatus. Starting at the spine of the scapula, just go up, and that where the mouse is this suprascapular notch, and suprascapular nerve going through that to innervate supraspinatus and infraspinatus. So you'll start there, and then above that is your supraspinatus muscle. So you'll track it out laterally. Next slide. You're going to hit the acromion, and then the supraspinatus is going to dive underneath. Next slide. And then come out the other side. And this is very similar to the image we got before, except it's not as crisp. So you see that ultrasound models lying on their side. Put them into the modified CRAFT position, and you go next slide. Voila, image is much better. And then you'll get a good picture of the supraspinatus going up into its attachment. And all through there, you can look for muscle tear or tendon tear, which will look, as long as you're pretty confident that you have a nice crisp image, will appear as the dark fluid. The ultrasound waves are just flying right through. Next slide. Case number 3. So 17-year-old female volleyball player jumped to spike the ball, knocked down by friendly fire, landed on her lateral shoulder, now has clavicle pain. So she has no deformity. She has soft tissue swelling over the AC. She's tender over the AC, full but painful range of motion, strength 5 of 5 with pain, neurovascular intact. She has a positive crossbody adduction test and a positive resisted AC joint extension test. So obviously this is AC joint sprain. So once again, this is something that you can look at with x-rays. You're really, unless it sprains a little more significant, it's hard to see sprains on an x-ray or tears on an x-ray from the AC joint. But with dynamic evaluation, you can do something called ballottement of that joint, where you have one hand pressing down on the clavicle, and then the arm is adducted at their side, and you lift up on the elbow, and that's going to stress that joint. And you can, if you have, a third hand, you can hold the ultrasound over that, and you see those images. The AC joint is being ballotted up and down, along with, you can see a pretty crisp tear with fluid going through there. Next slide. And so super easy image to get. You go over the AC joint with a linear probe and you look at it. This ultrasonographer didn't change the depth of the image. That's something that you would want to adjust. But that's what a normal AC joint should look like under ultrasound. Next slide. 16-year-old pitcher decided to throw a wicked curveball and felt a pop in his elbow. Now has pain and apprehension in that elbow. So this is UCL sprain. And I'll show you how to get that image. This is a little bit technically more difficult to see, but particularly on that bottom image, you can see top image is showing you an intact UCL in the elbow. And then bottom image shows you disruption of that tendon or ligament, sorry, and then the fluid in between. Next slide. So this is how to get that image. So the patient, if you look on the bottom right of the screen, the ultrasound model has their hand abducted above their head. And as ultrasonographer, you can use your leg to help them be a little more comfortable and to rest their arm on. So you're starting with what we call the ski slope image. So you have the medial epicondyle there with the common flexor. And then what you're going to want to do is slide a little bit more posteriorly and then flex the elbow to about 90 degrees. You can go to the next slide. You see the ultrasonographer doing that. As you do it, that's a good crisp image of the UCL. And what you can do when they're in that image is if you stabilize their elbow, you can stress that and see if there is any laxity in the ligament. Next slide. 14-year-old football player. Someone stepped on my wrist during a tackle, now with pain just proximal to the wrist. So no deformity, but it's got some soft tissue swelling over the distal forearm, tendon palpation over the distal radius. The wrist range of motion is intact but painful, and wrist strength 4 out of 5 due to pain. They're vascularly intact, and you're not cruel, so you don't do any special tests. So this is the sideline. You haven't sent this patient to the emergency department for the definitive diagnosis yet, but you're at least able to say, maybe you shouldn't be playing right now because I can see your distal radius fracture. So on the right side of the screen is proximal, left side of the screen is distal. You see the physis there, and then just proximal to the physis, you see that step off. So like we had said before with bone, really bright, nice and linear. All of a sudden there's this disruption and it's higher up and then it keeps going. So that is a step off. It's a fracture on ultrasound. Next slide. So 12-year-old basketball player that comes to your clinic with gradually worsening knee pain. So they have mild soft tissue swelling over the tibial tuberosity, tendon palpation over that same area. Tight hamstrings, otherwise range of motion is pretty normal and they're neurovascularly intact. So this is a clinical diagnosis. You should know that it's Osgood-Schlatter. You don't need to do x-rays necessarily with it. But one nice thing about ultrasound as compared to x-ray for this is that you can, because ultrasound picks up soft tissue so much better than x-ray, you can see things that are earlier in the development of Osgood-Schlatter that you might not be able to see with an x-ray. So this is showing cartilage swelling without bony fragmentation. You see that the tendon insertion is slightly thickened, and you see a fusion of the deep infrapatellar bursa where that arrow is pointing. That's not something you would see if you sent your patient for x-rays. So you'll have patients be like, oh yeah, they said it was Osgood-Schlatter, but everyone did x-rays and they were normal. Well, no, like you're developing Osgood-Schlatter, and you can see that with ultrasound. So this is more advanced. This one's showing fragmentation of the apophysis and a thickened distal patellar tendon on that left side there. So this is kind of, it's pretty easy to do an ultrasound exam of the patellar tendon. You can see that they have a little anisotropy on the left there. On the right patella, left, they're going over to the tibia. And then they're, once they've identified their landmarks, slide more distally to get the tibial tuberosity, you can go. And they haven't gotten quite rid of the anisotropy, but you can see it attaching over a nice crisp bone without any big effusion underneath the patellar tendon. Okay, next slide. 16-year-old basketball player went up for a layup, landed on another player's foot, inverting his own ankle, was unable to walk initially and can't walk now. Diffuse soft tissue swelling over the lateral ankle, tender diffusely to the area, no focal tenderness. Special tests deferred because you're not cruel. X-rays are, well, I think they would show soft tissue swelling if you, but the X-rays are negative. So obviously it's ankle sprain. One nice thing, once again, about ultrasound is being able to grade that sprain in your clinic, and if you're being nice and gentle at the sideline. So grade 1, you can grade sprains based off of presentation initially, if you're on the sideline or in the emergency department. Minimal tenderness and swelling for grade 1, and you can see grade 1 at picture A. That's actually, I like that image, really nice. It's not completely torn all the way through, but you see the disrupted ligament. And then grade 2 in picture B, moderate pain and swelling, decreased range of motion, may have some feelings of instability or apprehension, and they may need crutches or assistance ambulating. You can see the partial tearing, particularly at that big bottom arrow. You can see that it's disrupted, almost like a quarter to a third of the way through. Grade 3, images C and D, significant swelling tenderness. They're unstable and really can't bear weight. And images C and D show that. C, I think, is a little bit harder to read, but D, you can see both ends of that torn ligament and a whole bunch of fluid in between. Excellent. So once again, this is dynamic ultrasound. So one thing that you can do is once you find, and it's pretty easy to do, it just takes a little bit of moving the probe. Oh, I go back to the next one. Moving the probe around. So you can see on the right side, talus, left side, tibia, and then stretching in between that ligament. If you do an anterior drawer, you can see if there's any disruption of that for like a grade 1 or grade 2 particularly. Okay, next slide. And if you level out and go, and I'll show you in another slide exactly how to do this. If you go just up a little bit, you get the AITFL, so the anterior inferior talofibular ligament. So for that high ankle sprain, once again, you can do dynamic ultrasound with a squeeze test. We'll separate those two bones. You can see if there's disruption along with, does it reproduce their pain, and look at it under ultrasound, which you really can't do with any other imaging modality. So this kind of shows you where to go from each one. So going from ATFL, just a slight move upward gets you to the AITFL, and those are some pretty good images. Fibula and talus, and tibia and fibula to show you those two ligaments. So you can do really one nice thing, just 2 quick images gives you a lot of information about an ankle sprain. Case number 8. So a 21-year-old avid runner develops lateral lower leg pain after a sharp increase in intensity of training. They have underlying pes planus, no other major deformity, tendon palpation over the fibula, but really hard to localize. Normal range of motion, neurovascular intact, and no real findings on special tests. So you look under ultrasound and you find just generally kind of where they're tender, you're sliding it along the fibula, and lo and behold, you find a periosseal reaction related to a fibular stress fracture. Next slide. 17-year-old multi-sport athlete with acute on chronic thigh pain they experienced while sprinting. And they said it felt like I was tearing something. You have soft tissue swelling over the muscular portion of the thigh with overlying tenderness. They have tight hamstrings, otherwise range of motion is generally normal. Strength decreased due to pain on knee extension. So this is a mid-body rectus femoris tear with a hematoma. So you get 2 views there, axial view, rectus femoris, and sagittal view of rectus femoris. And so good crisp image around what you're looking for. One other thing about tears is you get, like I said, kind of with that other image, a shaggy appearance. It doesn't look uniform or regular. So the irregular pattern of that hematoma in both sections, and you see the central tendon on the right. But the fluid being dark, not reflecting any sound back to the ultrasound probe. Next slide. So we'll go over some basic interventions. Most people, unless they've had some experience, aren't comfortable with them. We do all these at Spark, and we'll talk a little bit about kind of what each one is and what to consider when referring someone to us. Another thing is if you want to learn how to do any basic stuff for like knee injections, or if you're able to legally to do these different types of injections, more than happy to kind of talk to you about that. So basic interventions, reasons to consider injection therapy. So for diagnostic purposes, like I talked about before, you can see the needle on the ultrasound. So oftentimes, you know, you'll have people come in, we sometimes call them blind injections. I call them anatomic injections, where you're not looking under ultrasound. And they had an injection for something before, and they're not sure if the injection worked. One nice thing is you can see the needle going into your target. You can inject your injectate, and you know if it had an effect or not, if it's helping or not. And you're confident that it went exactly where it needed to be. Another thing you can do is the injection of an anesthetic agent, often with cortisone, so that diagnostic and therapeutic type thing. Another reason to consider, if it's too painful to participate in physical therapy, you send someone for something for physical therapy, they can't do it, use an injection, they're able to tolerate it and get better. Their progress in physical therapy has hit a plateau, or for soft tissue intervention when surgery is not wanted or not indicated for that particular pathology. Needle aspiration, needle tenotomy, and then PRP, prolotherapy, and autologous blood patch. Complications and risks, infection, super low. Bleeding, usually not an issue. Okay, hopefully not. Pain at the intervention site, you're instigating trauma. Nerve damage, numbness or weakness for like 2 to 8 hours. So if you're injecting one thing and the lidocaine seeps over into a nerve, they'll get numbness or weakness, but that usually is going to dissipate with the lidocaine. Using sterile technique and ultrasound to identify structures makes these risks just absolutely minimal. So first one, corticosteroids. So their uses, they're anti-inflammatory. So this is going to promote range of motion strengthening while minimizing inflammation and pain, and also shrink inflamed or swollen tissues. So a picture of what a patient should expect. It takes about 1 week to build up to maximum efficacy. So what I tell people is like, look, you'll feel the effect of the lidocaine. So for instance, if it's like a knee injection or shoulder injection, they're going to feel great while the lidocaine's in there. Then that's going to wear off after several hours. And then even the next day, they might feel a flare from the steroid, and that dissipates after about a day. But the point is, won't work right away. It takes about a week, and then they kind of realize, hey, my knee or my shoulder feels better. And then 4 weeks of the steady state, and then 1 week it's metabolized off and finally eliminated. Total of about 6 to 8 weeks. A lot of shoulder and knee injections, 2 months is a pretty reasonable estimate, sometimes up to 3, depending on the patient. Good thing is insurance covers this. The steroids that we use, betamethasone, that's the most potent. That's good for soft tissue and bursa. Kenalog, I prefer that one. You can use triamcinolone. Less toxic to the bone, better for intra-articular injections. So the complications and risks, when I talked about a steroid flare, so they get an increased pain or soreness in that area. If they can get it for up to a week, in my experience, it's usually a day or 2, maybe 3 afterwards. If you use this a bunch around a tendon, you can elicit tendon rupture. So I'm cautious when I use it for something like that. Skin discoloration, if you inject too close to the skin, you can get lipohypertrophy and it'll seem more thin or more blanched in that area. Chondrotoxicity, so theoretically limit intra-articular injections. If you're using a higher potency steroid, Kenalog, you can consider more injections if it's something that's preventing them from having so this won't be necessarily y'all, but like an older patient that may need a knee replacement, you can kind of ward that off. A younger patient, maybe don't do it as much. And then Cushing syndrome or steroid effect. This is if you're using like a bunch of steroid. Elevated blood sugar, 1 to 2 weeks, some sleep disturbance, subtle menstrual irregularity, decreased bone density. If you find this is kind of going on with these injections, solution, you limit the number of injections at a time, 1 to 2, and you give holidays from the injections. PRP, so what you're looking at, that big image there, that red disc is the platelet-rich plasma that's been spun down by that machine. So the premise, you take the patient's own blood, spin it down 1 or 2 times to remove the layer of platelet-rich plasma and inject that into the problem area. So basically concentrated growth factors, those promote healing, strengthening, healthy inflammation, tissue remodeling, and repair. So another way that you can handle this is doing an autologous blood patch, and I'll tell you why you can consider this in a second. So PRP, the mechanism, like I said, concentrated elements of patients' own blood. Problem, insurance doesn't cover this. They consider it still experimental. It's pretty new. There's some good research. As research comes out, it's demonstrated more and more that it does work really well. Particularly, for instance, in osteoarthritis, works better than like Roostercomb or like Synvisc type injections for osteoarthritis. However, it's pretty expensive per injection. It can be 500 to 2,000 depending on what clinic you're going to. I'm sorry?
Can you do supports with PRP? Or if they had the Synvisc, do you have to wait? How long would you have to wait?
I don't know if that's been researched. Like I couldn't cite a paper that says this is what theoretically they act in different methods. So I don't see them necessarily inhibiting the effect of the other one. But once again, I can't cite a paper that has studied that. If it were me, I would stagger them or separate them. If you're considering doing both, like do one, have them come back in 4 weeks, see how they feel, try the other one. But oftentimes my approach to, like, if you're using it for osteoarthritis, is a stepwise approach. So Synvisc often, or not often, but is more likely to be covered by insurance. Like you can get insurance to cover that if someone has failed steroids. So I usually, if by the time I'm trying PRP on a knee, I have, if I'm going through my kind of stepwise process, would have already done something like Synvisc. Yeah. So an autologous blood patch, it's the same as PRP. It's just, you're just not concentrating it. So theoretically not covered by insurance. However, you can use it in conjunction with a billable code, such as needle tenotomy. So you can rig it in such a way so there's no cost to the patient to do it. Okay, next slide. And that's just basically taking their whole blood and injecting it back in. You're just not concentrating it. So, I'm sorry?
And you can't do that into a knee, is that correct? Into a joint?
I wouldn't do that into a joint. No.
Because of the whole blood?
Yeah, yeah. You're basically, yeah, you don't want to give them a hemarthrosis. That'd be super painful. So PRP, good for osteoarthritis and meniscus tear, as well as tendonitis, ligament and tendon injury, and soft tissue like plantar fasciitis. So you notice, like Leslie pointed out, that's osteoarthritis and meniscus tear are absent from autologous blood patch. You can use that for more soft tissue type things like tendonitis, ligament tendon injury, and soft tissue injury. Next slide. So needle tenotomy. So the premise behind this is creating a new injury pattern to promote reinvigorated healing and repair. You can use this in conjunction with lidocaine, so it kind of sort of using it sort of as like prolotherapy as well. So this is good for chronic injury that's no longer recognized by the body, like tendinopathy. So a patient has dealt with something for so long, but they've ignored it, and their body starts to ignore it. When you use this, you remind the body that the injury is present and they need to come address it. Insurance does cover this using CPT procedure codes. Nerve or tendon hydrodissection. So this is good for treatment of like entrapment conditions like sciatica, carpal tunnel, cubital tunnel, and things like that. Or for postoperative scar tissue, particularly around like the hip and the psoas. Once again, insurance covers this, and you can bill it as a trigger point injection. So those are fundamentally my resources, and next line. That's it. And that's my email and my phone number. If it's pertaining to patient care, feel free to text me. And also, I'm fairly decent, unless I'm on vacation, about responding to emails. So, any questions though? Sure.
I was just wondering, how do you determine when to use ultrasound? Like if you have a good history, people have done special tests and it's all pointing to like a very obvious diagnosis, would you still consider doing ultrasound? Is it more of like in difficult cases where you can't really tell, or?
Sure. So I would find, so for instance, something like the Osgood-Schlatter is like a good example. So one should be able to diagnose that without pretty much anything, unless they were concerned about like the degree of it, then you might consider x-rays, but in general, you kind of know what it is based on the history and physical. For imaging, when you're fairly confident of the diagnosis, if you're like, I would say 75, 80, 90% confident, sometimes I find ultrasound is very useful for demonstrating to the patient, like this is what you have in real time, to help them gain confidence in your diagnosis so that they actually engage more strongly in physical therapy and in their rehab. I find that actually works. And then also helpful for your, like let's say they come in for subacromial bursitis and you're fairly confident that's the diagnosis. You got the exam, you got the history, but using something like ultrasound can pick up on things that might hide in the diagnosis. So like calcific tendinosis, something like that. So lots of good reasons to use it even if you're confident in your diagnosis. I guess the personal ethics of it would be, if I'm not really using this, am I going to bill the patient for it? So it's for your moral discretion. I oftentimes, if I'm fairly confident of the diagnosis, but just want to show it to the patient, I don't bill, just because I think that's the right thing to do. If I'm using it genuinely for diagnosis, then it's a billing thing. But lots of great reasons to use it, even if you're confident. Just whether or not the patient pays for it is the ethical consideration. Yeah. Yeah.
I would say whether or not I use it is whether or not I feel comfortable. Like for instance,
Yeah.
knees, I've looked at a lot of knees with ultrasound.
Sure.
And I feel very comfortable that it's going to be worth the patient's time.
Yeah.
With
Yeah.
an ankle, I feel like I'm just still learning that. So
Right. Yeah.
when I look at it, I won't bill because I feel like this is more for my education.
Right. I do. Yeah. I'll do that if it's like something that I'm not like, yeah, I looked at it like 1,000 shoulders. Like if I'm looking at the shoulder, sure. Things that like posterior hip or something that there's a lot going on back there. So like if I'm looking at it and I don't feel confident in it, like something like that, like it's oftentimes for my own education, and you can pick up on stuff too. You always learn as you go. It's a practice of medicine.
Also, I feel like because it's sitting right there, there's almost no reason to not do it. Like
Sure.
Whether or not you
Yeah.
bill them, just because I guess I'm never completely confident in my
Sure.
diagnosis, and just being able to see that there's nothing else going on.
Right.
Or to
Yeah.
see that it's bilateral. Or,
Yeah, because the other thing, particularly if you're not billing, it's like zero harm to the patient to look with an ultrasound. They may lose 15 minutes of their time, but that's about it. Yeah.
You don't lose 15 minutes of your time.
Also, yeah, you
Sometimes
maybe,
I really
yeah.
want to ultrasound something and I don't really have time today.
Yeah, totally. Yeah, I'm confident in my exam. I don't need to ultrasound this. I have another patient sitting there waiting for me. Skip it. Yeah. So totally a good reason not to do it. Yeah.
and the other reason to do it is sometimes patients really want you to.
Oh, yeah.
They just feel, like you said, they feel way more confident if you show them something.
Yeah.
Even
It's
if there's nothing to see, like especially like patellofemoral is what.
Yeah,
the
you're
right
not-
type of
you may
image
not-
that they give me a lot. I don't often see much on ultrasound with that. Sometimes a little bit of inflammation or something, but that's really not a lot.
Yeah.
But they like to see.
Yeah, I hit this a lot in the emergency department where you'll hear people say, yeah, the doctor examined me, but they didn't do anything. And I don't tell them this because I don't want to get into a pickle, but it's like, no, the doctor did something. He went to, years of medical school and training, and he focused it all on you in that one moment. He did something. But yeah, to do the ultrasound gives them the sense that it is true. It's not just like you're giving them an illusion, but you are looking. You may find something that you didn't find before. But in terms of your relationship with the patient, it does build that. Like that doctor actually cares to take that extra time to show me kind of what they found on ultrasound and to go through that with me. And one nice thing about ultrasound too is because they don't know what they're looking at probably. So you can pause it, freeze it, take a picture, and then stop and show them everything. And that also actually, not only will it build their confidence in your diagnosis, but hopefully their understanding to be able to explain it to the next person along the line in their therapy, to their physical therapist, to their primary doctor, that kind of thing.
And this is when I first was working here and I was doing the exams, a girl was having posterior knee pain, and it didn't feel like a cyst or something. Something doesn't feel quite right. And so I did an ultrasound, and it didn't really quite know what I was looking at. I hadn't seen it before. It didn't look like an OCD lesion at all, but it looked like another piece of bone. And I was like, why is there another piece of bone? You may have already guessed what I'm going to say it was. So I took a picture, and I just kind of gave her a general diagnosis, and then I sent it to John Miner.
Oh, yeah.
Like, John, what is this? It was a flabella. And
Yeah.
I've never seen it on ultrasound the way it looks like, because it reflects.
Yeah.
It looked on there, and we can see there was inflammation around it, and usually they're not really the cause of the problem, but in this case it was
Happened to be. Yeah.
But that was just because I didn't know what it was, so I was like stabbed in the dark, and because of that, I mean, he looked at the picture and he could diagnose.
Yeah, that's another, I think with X-ray, when it comes to like bony fragments, it's a little bit easier to see, like, so for instance, you wouldn't be able to pick this up on like ultrasound necessarily, and so I think you were really good, but like for instance, like a bipartite patella, like you could see, the nice crisp round border, there's no signs of really fragmenting, something that's a little easier to see on X-ray. But if you're good enough, you can know where you're looking with the ultrasound and know that that's like a nice crisp bone. It's not like fragmented off from something. So yeah, cool. Any other questions?
Is there any specific certification or licensure do you have to have to do the ultrasound?
For
Somebody like athletic trainer,
sure.
you actually do it in the school setting, and before for them to send the kids to MDDO.
Sure. Yeah, you may have to review that like with your board. I'm not entirely sure for athletic trainers. I know for like as a physician, it sort of comes with so with your level of training, it's built into it. So for me, as an emergency physician, and particularly also doing like family med when they're going into sports might not necessarily have had the ultrasound experience, but because it's built into your training, that becomes part of your credentialing, kind of like automatically. So in terms of being an athletic trainer and using it as like for diagnostic purposes without having to worry about like legal repercussions of using it, that'd be something that you'd have to probably investigate. Do your board? I don't know if anyone else has any answers to that question. No? Yeah. It's a good question. Figure that out. Yeah.
This isn't a very definitive, but what I was told is if you're allowed to diagnose, you can use an ultrasound to do it. If you're someone who's not allowed to diagnose.
Oh, cool. Okay.
I
Sweet.
think that's a pretty general rule of thumb. I don't know how accurate that is. For instance, like a nurse could use an ultrasound just to look at something, but she couldn't make a diagnosis.
Oh, sure. Yeah, yeah.
Or, because she's not allowed to diagnose.
Yeah.
But if you're just a practitioner, you can diagnose. So that was like the difference that they taught us.
Okay. If you're legally, so yeah.
Legally
For
able to
anyone listening.
diagnose whatever you're looking at.
Okay.
Then you can use it to diagnose. You can always use it. Anyone can use it to look at it though.
Yeah, cool. So Leslie, for those listening, Leslie was saying, anyone can use it to just look at something. But in terms of using it as diagnostics, if your licensure allows you to make diagnoses, then you can use it for making diagnoses generally. Cool. 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 Any questions from anyone online? I don't see any comments.
That's what I came back for too.
Cool. Okay. Sweet. I don't see anything. Cool. And like I said, I've got the butterfly here. If y'all want to take it out, look at it, see it, just ask me. I'll hang out for a second. And then, yeah, then we'll see. I got children who are probably screaming right now. So at a home. They're my children. So don't worry about that. And it's my home.
Are they tuned